Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we are exploring the pulmonary divide of obstructive and restrictive lung disease, a fundamental concept in respiratory medicine based on how they alter airflow and lung volumes. Please note that this video is for educational purposes only and does not constitute medical advice. Always consult a qualified healthcare professional for clinical concerns. Now, let's look at the pulmonary divide. At its core, all pulmonary mechanical issues alter airflow and volumes in two primary ways. Obstructive disease is characterized by the phrase hard to get air out, where airways are blocked or narrowed, leading to increased resistance and air trapping, often resulting in a barrel chest appearance. Common examples include asthma and COPD. Conversely, restrictive disease is hard to get air in. Here, the lungs or chest wall cannot expand due to stiffness or physical restriction, resulting in small, shrunken lungs and a fast, shallow breathing pattern, as seen in pulmonary fibrosis or obesity. To differentiate these, we use the Diagnostic Engine, Pulmonary Function Tests, PFTs. The fundamental metric we track is the ratio of FEV1, the volume of air exhaled in the first second, to FVC, which is the total volume exhaled forcefully after a deep breath. A normal ratio is typically greater than 0.70. Beyond basic spirometry, we also look at total lung capacity, TLC, residual volume, RV, and DLCO, which measures how well gas exchanges across the alveolar membrane. DLCO is particularly sensitive to surface area destruction in emphysema, or thickening in fibrosis. Interpreting these results is easier with two simple mnemonics. For an obstructive pattern, remember OBU. The air is hard to get out, the ratio drops below 0.70, and it is the upper number, FEV1, that drops most drastically. You'll see a scooped-out flow volume loop and signs of hyperinflation, like increased TLC and RV. For a restrictive pattern, think REI. It's hard to get air R inside. The ratio remains elevated, or normal, greater than 0.7, and it is the inferior number, FVC, that drops most, keeping the ratio high. These lungs appear miniaturized on the graph, with decreased volumes. Let's look closer at specific obstructive diseases, starting with asthma. This is a chronic inflammatory disorder characterized by reversible bronchospasm, primarily driven by a type 1 hypersensitivity reaction. When a trigger like pollen enters the airway, it sets off a cascade: sensitization of Th2 cells, IgE antibody production, and mast cell degranulation. This results in the airway triad: fierce bronchospasm of the smooth muscle, intense wall edema, and the formation of thick mucus plugs. In a clinical setting, keep an eye out for Kirschmann spirals and Charcot-Leyden crystals in the sputum. Unlike asthma, COPD represents an irreversible spectrum of airway obstruction, heavily linked to smoking. We generally see two overlapping phenotypes: chronic bronchitis, the blue bloater, and emphysema, the pink puffer. Chronic bronchitis involves massive mucus production and inflammation, often leading to cyanosis and right heart failure. Emphysema, however, involves the destruction of alveolar walls by neutrophil elastase, creating floppy air spaces and a barrel chest. These patients hyperventilate and breathe through pursed lips to keep their airways open, often maintaining their oxygen levels longer, hence the pink appearance. Shifting to restrictive diseases, we categorize them as intrinsic or extrinsic. In intrinsic disease, the lung tissue itself is damaged, often becoming fibrotic or stiff due to occupational exposures like asbestosis, autoimmune conditions like sarcoidosis, or idiopathic causes. A key marker here is a low DLCO, because the thickened membrane impairs gas exchange. In extrinsic disease, the lungs are healthy, but the pump is broken. This can be due to chest wall deformities like kyphoscoliosis or neuromuscular dysfunctions like ALS or myasthenia gravis. In these cases, the DLCO remains normal because the membrane itself is fine. The body just can't move enough air. When it comes to management, our first-line therapeutics often target the physiological bottlenecks. Bronchodilators work directly on smooth muscle to force airways open. These include beta-2 agonists, like albuterol, which increase CAMP for relaxation. Muscarinic antagonists, like ipratropium, which block contraction-inducing acetylcholine. And PDE inhibitors, like theophylline, which prevent CAMP breakdown for sustained dilation. While bronchodilators treat the mechanical symptoms, anti-inflammatory drugs alter the actual disease course, especially in asthma. Inhaled corticosteroids, ICS, are the cornerstone of therapy, suppressing inflammatory genes and reversing mucosal edema. We also use leukotriene modifiers, like montelukast, to block late-phase bronchoconstriction, and biologics, like omalizumab, which bind to IgE antibodies to prevent the allergic cascade from even starting. Long-term management of asthma follows a stepwise approach. We escalate treatment based on symptom frequency, moving from as-needed SABA for intermittent symptoms to adding low-dose ICS for persistent cases. In severe, refractory cases, we might use high-dose ICS, LABAs, and even biologics. A critical clinical pearl to remember: a LABA should never be used as monotherapy in asthma without an ICS, as it significantly increases the risk of life-threatening exacerbations. For COPD, we use the GOLD framework, which relies on long-acting bronchodilators as first-line therapy. Patients are categorized by symptoms and exacerbation history into groups A through D, with treatment escalating from PRN bronchodilators to daily LAMA or LABA combinations. Importantly, only 3 interventions are proven to actually reduce mortality in COPD: smoking cessation, supplemental oxygen for chronic hypoxemia, and lung volume reduction surgery in selected patients. Now, what about emergencies? Acute exacerbations are sudden, dangerous worsenings of symptoms, often triggered by infections. You must recognize severe distress signs, like the silent chest, where airflow is too restricted to even produce a wheeze. The protocol is rapid: titration of oxygen, aiming for 88 to 92% in COPD, massive bronchodilation with duonebs, systemic steroids to crush inflammation, and often BiPAP to open airways and clear CO2. If these diseases are not managed effectively, they can lead to cor pulmonale, eventual heart failure. Chronic hypoxemia causes the pulmonary arteries to constrict, leading to pulmonary hypertension. The right side of the heart must then pump against this massive pressure, eventually enlarging and failing. Clinical signs include JVD, an enlarged liver, hepatomegaly, and pedal edema. To wrap everything up, this master clinical matrix provides a high-level comparison. Remember that while asthma and COPD are both obstructive, with low PFT ratios, asthma is often reversible with ICS, while COPD involves irreversible damage, best managed with long-acting bronchodilators. Restrictive diseases will show high ratios and low volumes, with DLCO helping you distinguish between intrinsic and extrinsic causes. We hope this presentation helped clarify the complexities of pulmonary medicine. If you found this session valuable, please like this video and share it with your colleagues and classmates. Don't forget to subscribe to CleanMedKE for more clear, structured, and clinical medical education.